Why?
Yeah.
Okay. Well, the saline implants, with time, almost all of them start to wrinkle. They are much more firm. So when you hug someone with a saline implant, a lot of times they're aware of it. They feel it's firm.
Interesting. Okay.
It doesn't have that
like
soft,
a water balloon.
Yeah, it doesn't
give?
have the soft texture of a silicone implant. The average lifespan of a saline implant is somewhere between 8 to 10 to 12 years, where the newer silicone implants are somewhere like 18 to 20 years. And the technology of the silicone implants, the newer generation silicone implants, which have a much thicker wall, they have what we call a cohesive gel matrix. If you cut an implant, a current silicone implant, and you cut it, it doesn't spill out. It's a silicone cohesive gel matrix. So it stays in place. It's like Jell-O. So the old implants, you cut it, it's a sticky, gooey mess of motor oil. So the newer implants, the technology is so much better, and they're very safe.
So is that going on, by the way? A lot of the people that had the other type of implants coming in to get the silicone?
The implants that were placed between the early 70s and the mid to late 80s were of that old style where they ruptured within 8 to 10 years, and they're a gooey, sticky mess. And I take those out now, and they're obviously very concerned, and they're still like chat rooms based on those old implants. But the new implants have been shown to be safe.
Now the implants themselves, you say, have changed over the years.
They have, and not only has the technology changed, like we mentioned before about the thicker envelope and the cohesive gel matrix, but now there's so many different shapes and styles that I can really tailor a breast to what the patient's desires are. It's not only just size now. You know, a patient can come and say, I want a small C or medium C or large C, and that used to be all we could do. Now I can say, well, do you want a natural appearing breast? Do you want some roundness? Do you want a very round breast? And I can totally control that with
So they're
the shape
making
of
the
implant.
implants different?
Oh, they have different styles. They have a high-profile implant, a very high-profile.
What does that mean,
moderate.
high-profile?
Well, if you take the shape of an implant, you can go all the way from a pancake, a low-profile implant. They'll give you a very natural result. There are some limitations with that, all the way up to almost a baseball.
So it just projects out.
It projects more. The diameter's less, and they give you more roundness at the top.
As far as over the muscle, under the muscle, what do you do?
I go under the muscle about 98% of the time.
Do they still go over the muscle?
Some people do, and I think it's a mistake.
Okay.
Why? The biggest reason to go under the muscle is the degree of capsular contracture or hardening of the implant. It's normal for the implant, your body's interface with the implants, to develop a thin layer of scar tissue around it. That's normal. Okay. Sometimes that gets hard in about 5% of the cases. And that rate is double on top of the muscle. Also, being a revisionary specialist, I see what these on top of the muscle implants look like 10 and 12 years later, and they kind of slide down the chest wall. And so instead of being here, the implants are now down here, and where they're under the muscle, they don't seem to slide as much, because when you go on top of the muscle, you're disconnecting those attachments from the muscle to the breast.
Okay, now what about your incisions? I guess you could go under the fold, to the nipple area, armpit, belly button.
Right.
What is your favorite? Do you have a favorite?
When I did the saline implants, I used to like to go through the armpit because I can make an incision this big. But now that I'm using silicone, it's hard to get a silicone implant through the armpit, you know, or you have to make a big incision, which negates the benefit of that. My favorite approach is the periareolar, right under the areola. It heals virtually.
What about incision scars, though?
It heals virtually perfect 100% of the time. I'm not going to say 100%, 99% of the time. I think once every other year I revise a scar.
What about loss of sensation?
That's real. Loss of sensation occurs. It occurs in somewhere between 5 and 10%.
More so when you go through the nipple than like under the fold or anything
No, that's
else?
a fallacy, actually.
What do you think about the surgeon that tells me, Randy, I don't like to go through the nipple, I like to go underneath because you don't want to touch the most beautiful part of the breast? What do you say to that? I mean, do you go through the nipple because the result is better, or do you do because it's easier to place the implant?
It's actually easier to place an implant in the inframammary crease. However, because I do such a high volume of revisionary and secondary breast surgery, I see that inframammary crease scar. It's very visible. A lot of times it rises up, and most women wish they never had that incision.
Is that right? Okay, well that's good to know.
Yeah, and when you go around the areola, it's hidden. They can wear bathing suits, and it heals so well almost every time. And
so nothing to worry about then?
It isn't, and it's a concern for people, but I can tell you it heals much better than any other scar.
Knowing I was going to interview you today, the women were talking, and they were saying, ask you, you know, the second time around, the second surgery, does it, I mean, a lot less pain?
Usually, yes, because the pocket's already developed. So a lot of
times.
When
you say the pocket, what do you mean?
Well, where the implant sits, there's a thin layer of scar tissue around. When I take out that implant, I don't have to do anything with the muscles or anything. Everything's already done. So if I have to modify that pocket, the pain is so much less than the original surgery.
Okay, lifting. We're going to take a quick break, but and I know you have photos, so we'll get to those. But breast lifts, you like breast lifting.
I love doing breast lifting.
Now, what about the incisions, though? Because you were saying that you don't always have to have that incision underneath the breast in every case.
Right. You know what? It depends on the degree of drooping, or what we call ptosis. And a lot of times I can do it just with an incision around the areola, and that's called a circumareolar, or a lollipop. I've virtually eliminated the anchor scar or that horizontal bottom scar from my repertoire. I don't
Is that
do
right?
it.
Really?
Yeah.
Really?
And that's something that's taken a long time to develop, and we call it circumvertical because you have to put the skin somewhere.
Yeah.
And so if you can organize it around the areola and work it in, you can just have what we call a lollipop around the areola and down. And generally those scars heal really well. I would say that's a misconception.
Is it?
A lot of women have a fear of that scar. And
The lift surgery.
Yeah, and I would say in most cases that scar heals really well, and that doesn't bother them at all.
Okay, now what about a surgeon that may say, well, most of the time you just put a big implant in there, that
Right.
creates a natural lift. What are your thoughts on that?
Well, common sense. If you're having drooping without an implant, what would happen if you put an implant that weighs a significant amount? It's going to droop more. And
Good
I see
point.
it all the time. I see, you know.
Oh, so you don't think it's a good idea?
No, women come to me all the time and I don't
right?
want scars. No one comes to me, hey, put scars on my breast. I don't want them. But sometimes they need that to get a great result. And, you know, if they go somewhere and the guy talks them into, a surgeon talks them into going a larger implant on top of the muscle, you know, invariably I see them 6 months or a year later and they have a way bigger implant than they ever wanted, and now their breasts are really drooped and they need a bigger lift than they otherwise would have needed.
What are the age ranges of the patient? Are they getting older and older?
Well, the age range is 18 to 60s.
60.
I'm seeing a lot of people in their 50s and 60s. They want to look good. You know, here in Southern California, everybody stays in shape and they look
Yeah.
good. And I see a lot of women in their 50s and 60s still in great shape and care about their figures and how they look.
Okay.
And they're having breast surgery.
All right, now we're going to take a quick break. We come back. I want you to take me through the process. How you determine size,
Okay.
And how you make symmetry, and questions about cleavage as well, how you're able to do that, and we'll get to those photos. You're watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. We're here with one of the most popular plastic surgeons here in San Diego County, Dr. Chasen. We'll be right back. You are watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, what you need to know if you're considering any type of breast surgery. With us we have board-certified plastic surgeon, Dr. Paul Chasen. Okay. If somebody's watching this, they're not happy with their breast, what can they expect? I mean, what happens on day one, and specifically, how do you determine size?
Okay, well,
Does that come up a lot, by the way?
that's crucial
Okay.
to what we do. I first want to hear their story. And listening is the most important thing.
Really? Okay.
Yeah, because people, there's categories. Small c. I don't want people to know I've had a breast augmentation. I just want to be big enough.
They say that, okay.
Well, all the time. I just don't want to wear padding and those kinds of things. Or I just want to be proportionate. Or I want large breasts. You know, you can categorize somewhat just by listening. And then I've developed a computer program that has dozens of pictures, and I can click, and it's a very visual sport.
Of real patients?
Of real patients.
Okay.
It doesn't have their face. And, you know, they can look at, a lot of women are sophisticated, and they can look at those pictures and say, too big, too small, too round, not round enough. And so it's kind of like going to the optometrist, click, 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 you know how they do that?
Yeah.
So we do that. We do that process. And so after listening to their story and then going through the process, you know, we virtually nail it 100% of the time.
Do they try something on?
No, you know what? I think it's inaccurate. You know, people try bags of peas or implants, and, you know, a size of an implant outside the body in a bra is totally different than what it is inside. And sometimes I think some surgeons take away their own responsibility by saying, well, you pick the size. To me, I feel like this is my 1600 experience.
Okay.
This is the patient's first experience. I'll take the responsibility. You communicate, we'll communicate on what you want to do, and I'll create that in the OR. Remember, in the OR, I have you laying down, I look at sizers. I have 100 so implants in my office. I put a sizer in, I lay you down, I see how it looks laying down. I sit you up, I see how it looks.
You say you
up.
sit people up to 4 times.
Absolutely. I'm a perfectionist.
To make it look right.
It's crucial. I mean, that's how they look when...
But that's not common, you say.
a lot of guys don't do it. I don't know why. To me, it's crucial to what I do.
But do women come in and say, and this is what other surgeons tell me, I want 250 or 300 cc's?
Right. You know what? It's very difficult because this happens very commonly. A woman comes in, she's referred by her friend had 300 cc's, and I want to look like my friend. But remember, the end ultimate shape of the breast, the end result of the breast, is their anatomy, their breast tissue, plus the implant.
Okay.
So, you know, you take 300 cc's on one person who has no breast tissue, and you put that same implant in somebody who has a fair amount of breast tissue, their end result's going to be different. So that's where my expertise comes in, because I have to look at their, like I said, chest wall asymmetries, how much breast tissue they have. If somebody shows me a breast that they like, I can duplicate that. And I do
Okay.
that by using sizers and my knowledge and experience on the table. So if they tell me they want 300 cc's, I'll ask them to show me a picture of what they like too.
Is it more art than science, or 50-50, 60-40? Because going into
I
this,
think it's art and craft.